So good morning, everyone. Thank you for having me speak today. My name is Mike Ruiz. I'm one of the cardiology residents, and today I'll be talking about cardio-oncology and echocardiography. So I don't have any conflicts of interest to declare. In terms of the objectives for today, we'll first start by reviewing the principles of cardio-oncology and chemotherapy-associated cardiac toxicity. This is a very big topic, so we're going to just highlight some aspects of how chemotherapy, radiation therapy can affect the heart, but we're really going to focus on cancer treatment-related cardiac dysfunction. We're then going to talk about left ventricular systolic function assessment with echocardiography in patients exposed to chemotherapy, and we'll talk about some of the nuances around LVEF reproducibility, strain analyses, and then talk a bit about myocardial work indices. Lastly, we're going to talk about the practical utilization of LVEF and strain in patients with undergoing chemotherapy, including prevention and surveillance strategies. So a bit of background: about 40% of Canadians will be diagnosed with cancer in their lifetime. This is a huge number, and I'm sure we can all think about friends and family members who have been diagnosed with cancer over the years. What's reassuring is that therapy is getting better, and mortality with various cancers is going down over the years as therapy is getting better. And this includes not only conventional chemotherapy and how we protect patients from its side effects, but also more targeted therapies and immunotherapy. But with cancer survivors, chemotherapy-associated toxicity is recognized as a leading cause of long-term morbidity and mortality. And so a field called cardio-oncology has emerged as a discipline to optimize these patients and prevent cardiac dysfunction and really treat and recognize complications of chemotherapy on the heart over time. So this is a figure from a review article from the European Journal of Heart Failure in 2020. And this was a collaborative effort with the ESC and other imaging organizations. And it really just goes to show all the different chemotherapies and how they can affect the heart in different ways. Our major focus for today is going to be on this side here, focusing on cardiomyocyte damage and heart failure that can occur over time, and some of the usual suspects that we'll see, like anthracyclines, doxorubicin, alkylating agents like cyclophosphamide, HER2-targeted therapies like trastuzumab, or VEGF-targeted therapies like bevacizumab, a monoclonal antibody, or sunitinib, a tyrosine kinase inhibitor. All of these agents can cause cardiomyocyte damage and lead to heart failure in patients exposed to these therapies. There are other side effects from different chemotherapies. So for example, platinum-based chemotherapies or antimetabolites 5-FU or capecitabine have been shown to cause endothelial dysfunction and can lead to coronary artery spasm, as well as thrombosis and MI. Radiation therapy is also something to think about and relevant to echo, though we won't talk too much about it today. But radiation therapy can cause accelerated coronary artery disease, leading to ischemic heart disease, can cause acceleration in valvular heart disease, and can also cause pericardial damage and thickening over time. Lastly, arrhythmias are also a side effect of chemotherapy. The microtubule inhibitors like paclitaxel and docetaxel can lead to arrhythmias, and some of the newer therapies like the Bruton kinase inhibitors like ibrutinib can also lead to a higher risk of atrial arrhythmias like atrial fibrillation. So it's a very big topic, and the goal for today really will be to focus on this box, on how chemotherapy can affect cardiomyocyte function and what we can do about it. In terms of the populations at risk, so this, thanks, Patrick. Sorry, just looking at the chat. So just in terms of the populations at risk, this multiple hit hypothesis really sort of developed, and it's been used in many different disease models, but is particularly relevant in the patients undergoing chemotherapy. Often these are patients that have some baseline cardiac disease, or they may have risk factors, and then they get exposed to chemotherapy, which is another hit on them and can lead to cardiac disease. It's also important to recognize that chemotherapy in and of itself can also make people feel weak, tired. It can decrease their ability to exercise, and that can worsen risk factors and worsen cardiac reserve. And so all of these factors really come into play with affecting cardiac disease and making the individual undergoing chemotherapy more vulnerable to cardiac morbidity and mortality over time. So this concept of cancer treatment-related cardiac dysfunction, you'll see this acronym a lot in my presentation, CTRCD. Cancer treatment-related cardiac dysfunction is one of the most, I would say, severe or one of the most areas of interest for chemotherapy-associated cardiotoxicity. And the biggest offenders tend to be the ones that I've listed here. So anthracyclines, for example, up to 48% of patients based on the cumulative dose of doxorubicin can experience heart failure and cardiac dysfunction. Cyclophosphamide up to 28%, ifosfamide up to 17%. These are commonly used in induction chemotherapies. Sunitinib up to 15%, and trastuzumab can cause a transient heart failure or cardiac dysfunction while the patient's being exposed to it. But combination with anthracyclines, the risk goes up much more significantly. There's a proposed model of cardiac toxicity classifications that I really like, type 1, 2, 3, 4, 5. And so type 1 refers to irreversible myocardial damage that's dose dependent. Doxorubicin is your classic example. Whereas reversible myocardial damage that's dose independent, like trastuzumab, is a type 2. And then there are other mechanisms that have been described, like coronary spasm, radiation exposure, myocarditis, Takotsubo, and conduction abnormalities, and those would fit in your type 3 to 5. So you may see these types when looking up cardiac toxicity. In terms of risk factors for cardiac toxicity, we can really think about therapy-related risk factors and patient-related risk factors. And so the lowest risk patient is the adult that's less than age 50, but greater than age 18. The higher, or sort of the medium risk is your 50 to 64-year-old that has maybe one or two classic cardiovascular risk factors like hypertension, dyslipidemia, obesity, insulin resistance, or smoking. And your highest risk patients are your patients that are older, greater than age 65, that have 2 or more cardiac risk factors like hypertension, dyslipidemia, obesity, smoking, diabetes. They may have underlying cardiac disease like coronary disease, valvular heart disease, or heart failure. And the patients who have reduced left ventricular systolic function or low normal EF are also in your highest risk group. In terms of the chemotherapy or therapy-related factors, I think the important things are to remember the therapies that I've talked about, and really you can see that all of the high-risk groups really include anthracyclines. So it's anthracyclines with trastuzumab, high-dose anthracyclines, anthracyclines with radiation therapy, troponin elevation post-anthracyclines. So really anthracyclines with your VEGF inhibitors, with your trastuzumabs, with your chest radiation really are your highest risk patients. Risk scores have been developed, and these have been developed retrospectively and have not been, have not been tested prospectively. But the cardiotoxicity risk score, for example, could be used, and it takes into account patient risk factors and chemotherapy risk factors, and assigns a score. And so you get a point for each individual risk factor you have, and you get a score based on the type of chemotherapy you're going to be exposed to, and that can give a sense as to kind of how high risk this patient is for cardiac dysfunction. Although again, these have not been validated prospectively. And so the CCS 2016 Cardio-Oncology guidelines I found are quite helpful for understanding this topic. And so they recommend that patients who are undergoing chemotherapy, really their cardiac disease should be optimized prior to receiving chemotherapy, as well as during and after their chemotherapy. And patients who are going to receive potentially cardiotoxic agents should really undergo evaluation of their LVEF. So various modalities exist to assess the left ventricular systolic function. Transthoracic echocardiogram is what we'll talk a lot about today. And the benefits of echo is it's accessible. The patient's not exposed to radiation, and you can do functional testing like strain analyses to gain more data to kind of help your patient. The limitations are, there can be variability, and we'll talk about that. There can be variability between image acquisition, interpretation, day by day with the patient. And so that can affect the reproducibility, and that can also, you have to keep that in mind when making clinical decisions. cardiac MRI has the best reproducibility and it has the most accurate measurements. And that makes sense, but obviously this is not practical to be used on a population-wide scale for tracking left ventricular systolic function. Access for cardiac MRIs is an issue, and I think we know that. And historically, cardiac MRI has not been used in oncology trials, though interest is certainly gaining in the understanding of how chemotherapy can affect the heart and what we can see on cardiac MRI as a result of that. Things like edema, scarring, fibrosis. And MUGA scan historically is what's been used to assess the left ventricular systolic function. This is a nuclear scan, and it provides the best reproducibility and historically has been used in oncology trials. But really, you got to keep in mind these scans, each time you do one, patients are exposed to significant radiation. And really all they can give you is an LVEF. So even though it's reproducible, you don't get any functional data in terms of what the valves are doing, the pericardium is doing, and additional analyses on the myocardium. So in terms of echocardiography for cardio-oncology, we think about our cardio-oncology studies in the lab or at your center. And really what this involves is assessment of the LVEF, either by Simpson's 2D assessment or by a semi-automatic 3D assessment. And we'll talk about some of the differences between these analyses. It also includes strain analyses like GLS or GCS. It includes volume assessments as well, if you're able to glean all of these points. And as well, it may include markers of RV function, may include velocity of TR and then IVC to get a sense as to sort of right-sided filling pressures, again, as sort of markers of heart failure. But the most validated pieces of information really are the LVEF and the strain analyses, plus minus the volumes. So I want to talk about this paper first. It talks about reproducibility and left ventricular ejection fraction and measurement. And really what this study did is it looked at 88 patients who had breast cancer, were undergoing systemic chemotherapy, and they had serial echocardiograms throughout their follow-up period. But the echocardiograms had no change in the GLS. And we'll talk about it more later on, but GLS or strain analyses are really thought to be the most sensitive, at least in terms of echo, the most sensitive analysis we have to detect early left ventricular systolic dysfunction. So the thought was, if these patients had no change in their GLS over time, then any change in the left ventricular ejection fraction over time would be due to things like reproducibility, image acquisition, or image interpretation. And so it was a really kind of neat way to design a study to really understand, how good are we at echo in our EF assessment and our volume assessments in patients with the cardio-oncology population. And so just as a starting point, they use different modalities. For example, Simpson's biplane, biplane with contrast, triplane with contrast, 3D, and 3D with contrast to assess the LVEF. And they also use these same modalities to assess diastolic volumes and systolic volumes. And all this chart is showing right now is that, within the study period, the LVEF didn't change. And for the most part, all of these modalities had an LVEF within the same sort of ballpark. So the LVEF, at least the absolute value, more or less was the same between these modalities. It was not significantly different. And same thing with the volumes. However, what was interesting is what they looked at, the temporal variability in the LVEF, obviously over time, between these different modalities. And so what this is showing is that the biplane with contrast, triplane with contrast, had a variability of an LVEF of roughly 5%, 5 to 6.5% over time between studies. So the variability was quite high with these. However, 3D, what's interesting is that the modality that was associated with the least variability was your 3D LVEF. And we saw the same sort of trend with volumes. Volumes tended to be kind of similar over time. There was some variability, about 20-ish mils, and about 8-ish mils for the diastolic volumes. But the variability was much lower with 3D LVEF. And what's interesting, or what I think this is due to, is that 3D LVEF is more of a semi-automated acquisition compared to the different modalities. And in fact, 3D LVEF with contrast, at least for these operators, was actually a manual tracing versus a 3D acquisition. And granted, if you can get 3D, images, the variability went down significantly with 3D compared to every other modality. So 3D LVEF tends to be the best. Part of it probably comes from these, had the best images, and part of it probably comes from the fact that, these studies were more automated. There's sort of AI involved, and there's less operator input, which probably leads to less variability over time. They then looked at reproducibility in LVEF measurements, and they assessed for intra-observer and inter-observer variability. And so what they did is they had two observers read the same studies. They read the same studies twice. So you read each patient's study twice at different time points. So they separated them out so you wouldn't be able to recognize and remember, and they put dummy studies in between. And so what this was trying to do is assess, what is the ability to reproduce an LVEF measurement. And they did the same thing with volumes. I won't show that because the trend is the same, but just what is reproducibility within observers and between observers. And so, what they found is that, the LVEF within observers tended to range about almost 3 to 4%, or differ between 3 to 4% within observers. And with all the modalities, with the exception of 3D. 3D was about half of that, was about 2%, and that's similar to the variability that we saw on the previous graph. Inter-observer variability was also about 5%, was about 2.7% differences in LVEF between observers. So not as good as within the same observer, but different, obviously, between observers. So what they calculated was this minimal change detectable. And so really all this is 2 times the standard error of mean. And so it just gives you a range. Like if you repeated a study for the same patient the next day with a different observer, different image acquisition, the LVEF for 2D modalities, biplane, triplane, could vary by as much as 10%. And 13% between different observers. And this went down to about 5% with 3D. So the results of the study confirmed that, our 95% confidence interval for 2D LVEF variability is about 10%. And this is analogous to the 10% change in LVEF that defines cardiotoxicity in asymptomatic patients. We'll talk about the definition of cancer treatment-related cardiac dysfunction. So really, LVEF, we have to keep in mind that LVEF can vary day by day. And I think we all kind of have that experience in our labs. And if we're going to make treatment decisions simply based on the LVEF, that may not be enough. The LVEF is a volume-derived index. It relies on geometry assumptions. It's load-dependent, and so these can all affect reproducibility. And it's a volume measurement, so you may not detect earlier contractile changes, and that's where strain comes in. So what is strain? So strain analyses. Really what we're trying to get at here is we're trying to get at the myocardial shortening. And so your myocardium is organized into layers. The layer that's most close to the endocardium has a longitudinal plane. The middle portion has a more of a radial plane, and then the most epicardial portion has a circumferential plane. And this leads to the movement of the heart, which is not just inwards, which is not just longitudinal, which is not just twisting, but a combination of all these things. And it really leads to the motion of the heart that we do see on echo. And so what strain tries to get at is it uses speckled tracking. So within the actual myocardium, the little speckles that we can see, and it tries to assess how those speckles lengthen and shorten over time, shown by this sort of cartoon diagram here. And strain really is the rate of deformation. It's expressed as a percentage of shortening and lengthening over time. And global longitudinal strain is the rate of deformation of the myocardium. So the change in the length from the base to the apex. So longitudinal strain is the longitudinal shortening layer here. But we can do shortening of the radial and the circumferential layers as well. Although most commonly we do longitudinal. And so assessing the myocardial strain can detect myocardial dysfunction before LVEF changes. I have a video here just for my cardiology resident colleagues. We have not seen strains. So basically, you take a 2, 3, and a 4-chamber view. The program picks the views. It tries to place a set of contours on here, and you're allowed to modify the contours at the base, at the apex, to try to get it to line up most with the myocardium. And then what it does is it tracks those speckles within the myocardium, it tracks shortening in the different segments, and it creates a plot. And you're allowed to modify this to make sure that you're happy with how this is moving, that is tracking the myocardium appropriately. And then when you do that for the 2, 3, and 4 chamber, 2, 3, 4 chamber views, it creates this bullseye plot that gives you a sense of what the strain is like in the different portions of the heart. It calculates an overall global strain number that we use, and these are various plots in the 2, 3, 4 chamber views. So this is how strain images are acquired. And as I mentioned, we can do strain, typically do it in the longitudinal plane, and that's, these analyses that we're probably most commonly seeing. But we can do it with, the radial plane as well. So the movement of the myocardium inwards and outwards in the short axis views, you can do strain mapping as well. And it can also be done in the circumferential plane as well for the twisting motion of the heart. And, this is an example of a patient who's exposed to chemotherapy, who has a pre-therapy LVEF of 61% normal, has a GLS of negative 20.1%, which is normal, and then they get exposed to a cardiotoxic chemotherapy, and the GLS goes down. We're talking about GLS because they're often expressed in negative numbers. I'm going to talk a lot about the absolute difference in GLS. So I hope it's clear. I hope it's not too confusing. But the absolute value of the GLS goes down roughly 3%, which is a significant drop. However, the LVEF only changes by 55%, and the patient's asymptomatic, so technically this does not meet criteria for cancer treatment-related cardiac dysfunction. However, over time, the GLS continues to go down, and now the LVEF has gone down. And so we started to recognize that GLS going down can predict left ventricular systolic dysfunction and drop in LVEF over time, and this may be an area to intervene. So there's a plethora of papers that have studied GLS and cardiac toxicity. I've taken a representative piece of a table from this review by Dinesh in 2013. And really all the studies show things consistently. In patients exposed to a chemotherapy that's known to be cardiotoxic, they get strain mapping. The strain, before is normal. The strain afterwards is abnormal. And so, for example, in this patient population of various cancers, breast, lymphoma, exposed to anthracyclines, a change in GLS of 2.8%, the absolute change in 2.8%, the relative change of 13%, had a pretty good sensitivity and specificity. And if it was done at 6 weeks, you could actually predict toxicity at 24 to 52 weeks. And so, this comes up again and again and again, that early drop or a drop in the absolute value of the strain really will predict the left ventricular systolic dysfunction over time. So, as I mentioned before, this concept, cancer treatment-related cardiac dysfunction, CTRCD, there are various definitions that have been, defined by different organizations. The most common ones you'll see from the ESC, they use a cutoff of an ejection fraction less than 50%, with a change in EF of 10% from baseline, and a relative reduction in GLS of greater than 15%. So not an absolute reduction in GLS. Again, GLS starts at 20%. A relative reduction, so like 2 or 3%, would be considered a significant reduction, and would put you at risk for cancer treatment-related cardiac dysfunction. The ESC has similar sort of cutoffs in terms of EF and GLS, but they use an LVEF of 53%. And other organizations, 55. They're all sort of in the same ballpark, but there are some slight differences. So just be aware of what your lab would be using for their cutoffs. Going back to the CCS guidelines, they recommend that the same imaging modality be used. So if you did a MUGA, or MUGA was done, do a MUGA, or if you're going to switch to echo, do an echo going forward. Just consistency, because the LVEF can change between modalities. And they do recommend that strain analyses be considered. And I think this recommendation, if the guidelines were revised, would be much stronger nowadays with the new evidence we have for strain being able to predict dysfunction. And then they also recommend the use of biomarkers. Biomarkers are less sensitive, and while they may be used in the oncology world, really haven't been shown to be super helpful in terms of predicting cardiac dysfunction or prognosticating. So I'm going to talk about a couple papers that do a bit more of a deep dive into these parameters and how we may use them. We'll talk a bit about myocardial work indices as well. So this is a paper from earlier this year called the Combined Echocardiographic Approach for the Diagnosis of Cancer-Related Cardiac Dysfunction in Women with Breast Cancer. And so essentially what this analysis tried to do was utilize LVEF and strain analyses and try to create an algorithm or a diagnostic model for diagnosing cancer treatment-related cardiac dysfunction, and it used a cardiac MRI as a reference standard. So this was not for prognosticating, this was for diagnosing. What they did is they studied 136 women. They underwent anthracycline with trastuzumab, so high-risk chemotherapy. And then there went serial echoes and cardiac MRIs pre and post anthracycline. And what was cool about this is they actually did the cardiac MRI and echo basically within a day of each other. So they could really correlate well the changes seen with the different studies. They monitored for cancer treatment-related cardiac dysfunction using the definitions that we just talked about for echo as well as for MRI. And then they looked at parameters like 2D and 3D LVEF. They looked at global longitudinal strain, global circumferential strain, and they also looked at troponin and BNP and tried to correlate these with cancer treatment-related cardiac dysfunction. What they found is just sort of the preliminary information that they gleaned is that the changes in GLS occurred before LV dysfunction on cardiac MRI, and so this is something we've seen consistently is that the changes with GLS can be seen earlier before your LVEF goes down, and that's true for echo, and that's also true for cardiac MRI, and that's what's shown in this graph here, where these blue lines increase before the LVEF starts to worsen on cardiac MRI. They found that for the most part, cardiac MRI, 2D LVEF, and 3D LVEF really seem to be more or less within the same ballpark. They calculated similar risk, and so these modalities are good for detecting cancer treatment-related cardiac dysfunction. There were some patients that are obviously being detected by the MRI that are not being detected by by LVEF, by echo, probably highlighting the sensitivity and perhaps the accuracy of cardiac MRI over these analyses. So then what they did here is they put people into two groups. Either you had cancer treatment-related cardiac dysfunction, that was the blue group here, or you had no cancer treatment-related cardiac dysfunction, you were fine. You didn't have any drop in your LVEF, and those were the people in the orange group here. And so, not surprisingly, patients who had cancer treatment-related cardiac dysfunction in the blue, by cardiac MRI, their LVEF went down. By 2D echo, their LVEF went down. By 3D LVEF, by 3D LVEF, their LVEF went down. So my point is that, it's not surprising that their LVEFs went down over time and were quite similar between these modalities if you had cancer treatment-related cardiac dysfunction, because that's the point. That's the point of the analysis is assessing the LVEF. What they also found is that looking at the other parameters like global circumferential strain and global longitudinal strain, is that the absolute value of the global circumferential strain and global longitudinal strain was worse compared to, was worse in the patients who had cancer treatment-related cardiac dysfunction. That's in the blue here. Their GLS numbers were like 18-ish, close to 20 in the patients who did not have cancer treatment-related cardiac dysfunction. And that makes sense, right? If they should have abnormal strain analyses if they have cancer treatment-related cardiac dysfunction. What's interesting is troponin and BNP really were not sensitive or were not entirely helpful in differentiating these two groups. So these did not make it into the final model. So what they did, a bit of a busy graph here, but what they did is they created an algorithm. So basically, if you took your 3D LVEF, your global longitudinal strain, and your global circumferential strain, and you analyze them sequentially, what would be your probability in actually detecting cancer treatment-related cardiac dysfunction with the cardiac MRI as the gold standard? And so going through the algorithm step by step, if you're 3D, and we'll talk about 3D LVEF, the trend for the 2D LVEF is the same. The numbers are not as good as 3D LVEF, but the trend is more or less the same. And so we'll just use the 3D LVEF as an example. And essentially, 3D LVEF, if you detected cancer treatment-related cardiac dysfunction, for example, the drop in LVEF by the definition, then about 76%, you had about 76% chance of detecting someone who actually had cancer treatment-related cardiac dysfunction. What if your LVEF was completely normal? And so if your LVEF was normal and your strain analyses were normal, I put these annotations here just to help orient everyone. But if your LVEF was normal and your strain was normal, so for example, the strain longitudinally and circumferentially did not decrease by a relative change of 15%, then your chance of detecting cancer treatment-related cardiac dysfunction was extremely low, 1%. And then there's this middle group where they have a normal LVEF and the GLS is normal, but the GCS is abnormal, and then that's like a 6% chance of detecting it. Or your LVEF is normal, but your GLS is abnormal and your GCS is abnormal. That's like a 15% chance. And so there's the extremes of if your 3D LVEF is abnormal, you're highly likely to have cancer treatment-related cardiac dysfunction. If your LVEF is normal and your strain analyses are normal, your chance of cancer treatment-related cardiac dysfunction is extremely low. And then there's this middle group here, and they calculated different sensitivities and specificities for each of these different groups. And so what the authors conclude is that if a patient has cancer treatment-related cardiac dysfunction, as I mentioned, if your LVEF is abnormal by 2 or 3D methods, your probability of having cancer treatment-related cardiac dysfunction, as defined by cardiac MRI, is high, 60 to 77%. These numbers are, they're not perfect. It's not like 99%, but it's pretty good. It's pretty good on a population level. And if you don't meet the criteria for cancer treatment related cardiac dysfunction by LVEF, but you had abnormal strain analyses, this would be your sort of intermediate population. So this would be this group in the middle here, this intermediate population. And what they recommend is that, for these patients, it may be worthwhile if the GLS and the LVEF are abnormal, it may be worthwhile going back and looking at the LVEF. Is your LVEF measurements accurate? Are you happy with the contours? Because re-reviewing the LVEF, if the LVEF is indeed abnormal, then that would put this in a higher risk group. If the LVEF, you're happy with that assessment and the two values are discordant, this may represent a patient that will get dysfunction over time and someone you monitor more closely. They also recommend, you could consider a cardiac MRI to assess the LVEF in these situations, but I don't think that's entirely practical. And I think the last major takeaway from this is that if the LVEF does not meet the cancer treatment-related cardiac dysfunction criteria and the GLS is within normal limits, then this really represents a low-risk population. So your chance is low at roughly 1%. And so this can be helpful, in the patients who are at the extremes, obviously, of abnormal LVEF versus completely normal LVEF and strain, but also help us to think about what to do about those patients that are in the middle, in that gray zone. And so a new frontier, and the last little bit I'll talk about is a bit about myocardial work indices. And so strain has really good sensitivity in terms of detecting the subclinical left ventricular dysfunction. It's highly reproducible, and a lot of that probably comes for the AI and contouring and the minimal, variability. And also, in order to do strain, you need good quality images, right? And so that also helps with reproducibility, obviously. But one limitation is that different loading conditions can directly affect wall strain and GLS. So for example, if the patient has a markedly higher blood pressure on one day, this can be represented as higher afterload, and the GLS can actually look worse than it actually is. And so myocardial work indices are a way to get around this, and they incorporate loading conditions like blood pressure to help resolve this issue. And so what are myocardial work indices? This is something completely, that I had never heard about before, and it's kind of cool to learn about. So if you remember back to physics, work is the product of force and length. And what myocardial work indices try to estimate is basically we're substituting force for pressure. So pressure within the left ventricle, and length we're substituting for strain. And it's not a perfect calculation to actually get work, but it's good enough, and it provides an estimate or an index of work. And so essentially, what we can do is we can actually estimate the LV pressure using normal curves, and I'll show how those were derived. But we're able to actually estimate the LV pressure, and then with the LV pressure, you can then map the strain through the cardiac cycle with the LV pressure, and that creates a pressure strain loop. So this is an example from a review that shows that this is a canine model, and they have the baseline strain here in orange. And then what they did is they constricted the aorta. And so they markedly increase afterload here, and you can see the GLS drops from like 25% to like 21%, right? However, and so this would be detected as a drop in your GLS, and shows that with higher afterload, GLS can be affected. But then what they did is they created a pressure strain curve, so pressure in the y-axis, strain in the x-axis. And what they basically do is they mark the changes in strain with changes in the LV pressure over time. And the work is the product. So the work is the area within each of these loops. And so what they actually found is that the area is basically the same between these. The myocardium is doing the same amount of work, even though the afterload has increased and the GLS has dropped. And so it goes to show, this could be a potentially useful analysis. If your GLS drops, is the myocardium actually doing less work? Like what's going on there? And so in order to do this analysis, you need to estimate the pressure within the LV. And obviously patients can't have invasive coronary angiography or LV pressure measurement every time they have an echo. So what these authors did, a very interesting study that used initially canine models and then patient data. And what they did is they invasively measured LV pressures at different loading conditions, and they created a set of curves. They gated each of these curves. So what these are, this refers to the mitral valve closing, aortic valve opening, aortic valve closing, mitral valve opening. And so they gate it to the opening of the various valves, and they created a normal curve. Once they validated this model, they did it for humans, and they created a curve for humans. They created a normal curve for humans, and then they were able to take this normal curve, and you plug in your own patient data. You plug in whatever their systolic blood pressure is, and so that gives you the peak of this curve here. And then you plug in the time for the aortic valve opening, the mitral valve closing, the aortic valve opening, aortic valve closing, mitral valve opening, and then that will contour an LV pressure estimate for your own patient. So I thought this was a really kind of cool analysis. And this has been validated. Focusing on this group here in B, what they did is they measured the pressure volume, the pressure strain loops. So those loops that I talked about here, they measured the area of the pressure strain loops by estimated left ventricular pressures and strain by speckled tracking echo. And they compared that to invasive measurement of left ventricular pressure and spectral tracking echo. So really the variables here were estimated LV pressure versus measured LV pressure, and really you can see they correlated beautifully. So the areas were the same with this, really showing that this this method is valid and reproducible. What's also kind of cool what these authors did is they then they took their various so what you can do with these pressure strain loops is you can measure the area for each segment of the myocardium. So this is, for example, the loop that you would get for the lateral wall. This would be a loop for the septum, for example, in a patient who has a bundle branch block. And so you can measure the area from this, and then you can create a bullseye plot, much like you would for strain analyses, for each of the different segments. And what was kind of cool is that they then took some patients and they did PET analyses, and they said what is the glucose usage in the different segments of the myocardium. And you can see the bullseye plots are they're pretty close. The areas that are working hard, so these areas here on the on your work bullseye plot here, they're working hard, had high uptake of glucose, and the areas that are not working as hard here had lower uptakes of glucose, providing some kind of biological plausibility to all of these work indices. And so this kind of summarizes the idea of myocardial work indices. Essentially, you do your strain mapping as you usually would. You create your bullseye, you create your curves for the different segments. You measure the patient's blood pressure. You then create an estimated LV pressure curve by gating it to the patient's blood pressure and the closure of the valves through your Doppler assessments. And then that creates a pressure strain loop, which can be done for each segment of the myocardium. You can then measure the work. So the work is the area of this curve, and you can measure the work for the different areas of the myocardium, and you can do different analyses with this. So it's really interesting, I think. The limitations of these sort of analyses is that, you know, the normal curves estimate LV pressures were created in normal ventricles, and so they may have inaccurate work estimates in patients who are dilated. And the non-invasive peak pressure generally correlates to the LV pressure, but if the patient has LVOT obstruction or aortic stenosis, obviously they will not correlate. And so there's different analyses that you can do. I think the most important one is the idea of the global total, the global work index, the GWI, which is the area of the pressure strain loop. The global constructive work is really, this is the effective work. So this is the shortening that occurs during systole and relaxation or lengthening that occurs during isovolemic relaxation versus wasted work, which is work that's not helpful. So this is negative work during systole. So if a segment lengthens during systole, that's not helpful, obviously. Or if they start to shorten and contract during isovolemic relaxation, for example, if they have a conduction abnormality, that's also not helpful for doing work. So this is considered the global wasted work. And you can create an efficiency coefficient using these values to see how efficient your myocardium is. This is an example of a myocardial work index with the pressure strain plots, the bullseye plot you can produce, and then assessments of constructive work versus wasted work. And so normal values are summarized here. I'll just go over this just to get to the last couple papers I want to discuss. So, you know, what Dinesh and the group did, this was just published in May, was they looked at the prognostic value of these work indices for patients with cancer treatment-related cardiotoxicity. And so really what this was trying to do is, you know, we know that GLS can vary based on afterload conditions. So can work indices be helpful? And the addition of, you know, this model, estimated LV pressures and systolic blood pressures, can that help to improve the accuracy in diagnosis of current and future cancer treatment-related cardiac dysfunction? And so they took the same patient population we talked about in the previous study. They did echoes every 3 months. They did cardiac MRIs with that as well. And they measured strain. They did work indices, and they measured LVEF by cardiac MRI. And so what they found is that, you know, over time, in the patients who had cancer treatment-related cardiac dysfunction by cardiac MRI, so they had a drop in their LVEF, the LVEF went down. It makes sense, right? LVEF is going to go down if you meet the definition of cancer treatment-related cardiac dysfunction. Earlier than that, though, the strain analyses tended to worsen. And the work indices in terms of the global work index and the global constructive work were also significantly different between these groups as well. And so that makes biological sense that, you know, if your strain is going to worsen, your EF is going to eventually worsen over time, your work is also going to worsen over time. They did look at the other indices. They looked at things like blood pressure and heart rate, which did not actually change over time. Again, another sort of busy plot, but what they tried to do is you know, for patients who had current or concurrent cancer treatment-related cardiac dysfunction, so you're trying to make a diagnosis of cancer treatment-related cardiac dysfunction, if your GLS was abnormal, you had a pretty high, your probability of having cancer treatment-related cardiac dysfunction was about 20%. What's interesting is that if the GLS was normal, but your GWI was abnormal, so your work index was abnormal, you still had a pretty good risk, 24%, of having cancer treatment-related cardiac dysfunction. And what's interesting is this shows that, you know, these patients that had a normal strain but had an abnormal work index actually had a decrease in their blood pressures over time. And so this really shows, you know, the value in this sort of analysis. What's also kind of useful is that, you know, if your GLS and your GWI, so your strain and your work indices are completely normal, your chance of cancer treatment-related cardiac dysfunction is low. They also studied this for looking at future risk of cancer treatment-related cardiac dysfunction. And again, if your GLS was abnormal, then your chance of cancer treatment-related cardiac dysfunction was about 26% in the future. But if the GLS was normal and your work indice was abnormal, your chance was lower. So it had sort of less benefit, although still did detect some patients who had cancer treatment-related cardiac dysfunction over time. Again, what's also helpful is again, the extreme of it. If your GLS is normal and your work indice is normal, your chance of cancer treatment-related cardiac dysfunction was 0% in this study, so very low. So what the authors conclude is that a global work index can be useful for diagnosing with an odds ratio of 1.73 and prognosticating cancer treatment-related cardiac dysfunction when used alone. But when combined with GLS and the models that I just showed you, its value was really limited. You know, if your GLS was abnormal, that was often good enough to detect cancer treatment-related cardiac dysfunction. Although there did seem to be some patients in which the work index was helpful in detecting this. And normal strain and work indices can identify patients with the lowest probability. So that's also kind of helpful. If your strain is normal and your work indice is normal, then your chance of cancer treatment-related cardiac dysfunction was low. So what do we do with this info? This is a review from 2018. I find it very helpful. And essentially, if a patient is going to be started on cardiotoxic cancer therapy, getting a baseline echo is helpful. Get the LVEF and the strain. And if the LVEF is completely normal, really optimize their risk factors and go ahead. If the LVEF is 50 to 59%, but the strain is normal, they have preserved systolic function, you'll keep an eye on these patients. But if the LVEF is low, then subclinical left ventricular systolic dysfunction, and you really want to think about starting cardioprotective therapies. If the LVEF is abnormal, so less than 50%, these are patients you should really think about starting cardioprotective medications and talk with the oncologist. And if the LVEF is less than 40%, you may want to think about alternative chemotherapies. So prevention of left ventricular dysfunction with chemotherapy, you know, the usual stuff we do. Think about risk factors, optimize the risk factors, blood pressure, encourage exercise, which can be hard on chemotherapy, but it's very important. And then don't forget to think about other causes of LV dysfunction. If the patient develops heart failure, then a multidisciplinary approach can be helpful for thinking about cardioprotection. The last thing I'll talk about is just the use of strain in cardiotoxic chemotherapy. I'm aware of the time, but just a few more minutes, we'll finish this, this important paper. So this is the SECOR trial that was just published last year. And what they looked at is if GLS-guided cardioprotective therapies, so if your GLS went down and that triggered you to start cardioprotective therapies, could that prevent LV dysfunction over time? And so this was an international multi-center prospective randomized controlled trial, about 331 patients undergoing some of your high-risk chemotherapies, and they had baseline risk factors as well. You were excluded if you had LVEF less than 50%, valvular disease, or contraindications to the therapies they were exploring, like ACE inhibitors, beta blockers. The interventions were cardioprotective therapies, ACE inhibition and beta blockade, and the outcomes were LVEF change from start to the end of follow-up. And so they divided patients into two groups, the GLS-guided surveillance versus the LVEF-guided surveillance. And so if your GLS dropped, you know, a relative change more than 12%, you were then started on cardioprotective therapies. Your EF had to drop by 10% if asymptomatic, or 5% if symptomatic and less than 55%, in order to be started on cardioprotective therapies. Those were the main differences in the treatment arms. And what's interesting is that in patients who had a GLS-guided therapy, and were started on, and so let's say your GLS went down, that triggered you to start on cardioprotective therapies. Your change in LVEF from start to finish was only about 2.9%. And that was comparable to the patients who did not trigger starting therapy. So these were patients who did not have changes in their GLS. They were not triggered to start therapy. And the LVEF change in the GLS guided group was the same. What's interesting is the LVEF guided group, you know, these were patients who had a decrease in their LVEF. They then received the cardioprotective therapy after the LVEF had dropped. And by the end of the study period, their LVEF remained significantly reduced compared to all the other groups. So it really goes to show that the GLS, the drop in the GLS can really trigger you to starting cardioprotective therapies and help to prevent left ventricular systolic dysfunction over time. This is one of the first papers that actually has shown this strategy in a prospective manner. So, you know, again, about 13% had a drop in their LVEF compared to about 6% in the GLS group. This was a relative risk reduction of 57%, and a number needed to treat of 13 to prevent one cancer treatment-related cardiac dysfunction. So that's pretty good. And if anyone's curious, the regimen they used was ramipril and carvedilol, and they started them at basically ramipril started first, then carvedilol at week 4, and they titrated them according to the schedule if you're interested in employing the strategy for your own patients. Surveillance, really there's different guidelines that are available. I'll just leave this slide up here for a second. Essentially, anthracyclines, trastuzumabs, and VEGF inhibitors. Really, the beginning of therapy and end of therapy is extremely important. Trastuzumab every 4 cycles, and the VEGF inhibitors, you want to do an earlier assessment, and then every 6 months while they're on VEGF therapy, and then think about surveillance over time as well, because some of these therapies can have late effects. So in summary, cardiac toxicity is a major complication of chemotherapy use, and the patients at the highest risk for cardiac toxicity include older patients, 2 or more cardiac risk factors, pre-existing heart disease, high-risk therapy like those high-dose anthracyclines we talked about, anthracyclines plus trastuzumab, or anthracyclines with VEGF inhibitors, or anthracyclines with chest radiation. Anthracyclines, doxorubicin, but those combination therapies really put the patient at highest risk, and as well as with pre-existing risk factors. Accurate assessment of LV systolic function is key to monitoring cardiac toxicity, and really the semi-manual techniques or the semi-automated techniques like 3D LVEF and GLS seem to improve reproducibility over time. Strain analyses can detect subclinical left ventricular systolic dysfunction and predict deterioration over time. And integrated approaches with LV assessment and strain can really aid in the diagnosis of cancer treatment-related cardiac dysfunction. Again, thinking about those extremes, the ones that have an abnormal LVEF or the ones who have completely normal LVEF and strain represent the highest and the lowest risk, respectively. Lastly, myocardial work indices are relatively new analysis that are being explored and correlate with cancer treatment-related cardiac dysfunction. Though if your strain is abnormal, the work indices don't seem to really add too much, but maybe we'll learn more about these in the future. And then preventing cancer treatment-related cardiac dysfunction involves optimizing risk factors, encouraging exercise, and initiating those cardioprotective agents, the ACE inhibitors and beta blockers. And a reduction in the GLS, shown in the SECORE trial, can be a helpful trigger. So if your GLS becomes abnormal before your LV, this may be a patient you consider starting on cardioprotective therapies, especially if they're the higher risk group, the ones that are receiving the higher risk chemotherapy or have risk factors. And surveillance should keep in mind not only the risk during therapy, but as well as risk down the road. So these are the papers that I've cited. I'm happy to provide papers or my slides if anyone's interested. This is my email. If you have any questions or would like any of the information, please feel free to email me. I'm happy to open up the floor to discussion and answer questions. Thanks for paying attention.
So thank you, Michael, for such a whirlwind of information on cardio-oncology. Very, very comprehensive and provide a great update to our knowledge. So just want to give a bit of a historical perspective as an echocardiographer and the community of echo people. We've been trying to convince the oncology people for more than like 15 years to actually use echo for EF assessment rather than using mugger. Because before most patients will actually get started on chemotherapy either before and thereafter every 3 months or so having a mugger. So that involved IV and also radiation and so on and so forth. So it's actually quite frequent. So it took a collective effort of the echo community to convince the oncology over time that echo is as good in terms of ejection fraction, and thanks to many of our researchers and especially Dinesh, who's made a huge contribution in this area, as well as the GLS finally really sort of like allows the oncology community to actually turn over to echo as the primary source of estimating ejection fraction and also following the patients over time and actually changing the course of management. So it's really a huge win for the echo community. So once again, thank you. With a few minutes, I have a questions for my group because right now we do 2D EFs by Simpson and we do 2D EF by with contrast, and obviously 3D EF over in many different papers show that the reproducibility is actually better. So I think we try to implement that, but not all our machines can do 3D EF right away because only certain machines have 3D probes. So Let's go to the sonographer group. What do you think about, using 3D-EF all the time? Is that possible for us? Is that feasible? And how does everybody feel from a sonographer point of view? Can they speak in the... Hi, Janice.
Hi.
Yes. Need your opinion.
My opinion.
We can hear you.
It's the others.
Very important.
Yeah, I don't know what it entails to do 3D because I don't think we.
I think the image quality's there.
Yeah, I guess Emily says image quality will be a factor for sure in probably.
Can I say something?
Yes. Yeah.
Can they hear me? Anyway, we've been practicing a lot with 3D, but no one has really sit down with us if we're really getting the right answer.
That's right, yeah.
So again, I think we need to revisit the process so that we can move forward in terms of getting the LVEF 3D.
So more training.
Okay, that's very important message. Yeah, do we have enough machine with 3D probes to do this for cardio-oncology cases?
Yeah, all our machines have 3D probes. I'm not sure about the software levels, but they all have 3D probes.
Wonderful. So we're almost there. Yeah, one of our challenges not being able to do it post-processing for many of our GE images or even the Philips images. So that's something that we can work on as well from our end. Maybe we can look at using other external software to do that. Okay, so that's feasible. So thank you for the message. So we can look at that in September. So like really work on our 3D-EF aspect of it, because I think that's something that we could improve our workflow based on what the most contemporary suggestions in the literature. Okay, any other questions? Thank you.
Chiming, it's Kim here. Mike.
Hi, Kim.
Hey, Chiming. Mike, great rounds. Just, well done, very comprehensive review. And, we're very lucky to have Dinesh, sort of leading the charge here. Just a reminder to everyone, including trainees, that although these reductions in longitudinal strain and so on are important, that in fact, for most forms of cancer, the competing risk as you get elderly is just stock standard coronary disease, and that becomes a greater likelihood of mortality event than cancer-related chemotoxicity. So just a plug that you've got to watch the risk factors and address those risk factors and treat all the normal things, because it is always surprising how frequently that these are missed. I think in the concern and worry about treating the malignancy that often you can imagine when folks are having chemotherapy, they're not eating well, they're not exercising. We see clear changes in glycemic profile, metabolic profile, worsening of lipids, reduction in exercise capacity, increasing blood pressure, etc., that are not only chemo related, but that are non-chemo related factors. And these generally the things that actually cause the morbid events. So as you know, if you're a female and you're over 70 and you have breast cancer, if you survive more than 2 years beyond the initial event, the thing that's likely to drive your mortality event is not the cancer, but it's actually the competing cardiovascular risk. We see the same thing with males with prostate cancer. So yes, it's extremely important to do, as Mike has gone through the nice work here to identify and recognize the reductions in GLS, but in fact, as a competing risk, it's more important to stick to what we should be doing, which is good cardiac risk protection itself, to be honest. So don't forget that, and make certain that you monitor that. And I think we've got to learn a lot because, as you know, if we try and get an echocardiogram for our non-cancer patients, it's often not so easy, even in Ontario, yet somehow for our cancer patients, we seem to be able to schedule them on a very regular basis and follow up. So I think for our heart failure and other patients, we've got to learn from this strategy and move it forward. So it's interesting how different fields of medicine have been successful in coming up with strategies with the appropriate use of these modalities, where other areas we haven't done so well. So that's sort of more of a comment about how I think we need to more sort of algorithmize, if you will, other areas of cardiovascular medicine. But great talk, Mike. Thank you. And the work, the work stuff, you know, it's a bit complicated, the work indices. And where they sort of fall down a little bit is you probably need to do changes in preload reduction and so on to really understand what it means in terms of the hemodynamic responses, as opposed to just taking those steady state pressure strain curves. And that's where it gets a little complicated in how we would actually practically use these moving forward. So they do need a little bit more work before they become prime time.
So thanks,
well
Dr.
done.
Connolly.
Great comments. I think let's also speak to another topic that is actually very hot these days. Is actually oncology rehab. So as opposed to be cardiology rehab or cardiac rehab, now there's a whole field on oncology rehab. One of the interesting lecture that I attended was actually one of the Canadian, there's a lady cardiologist colleague who went to Nasser and actually did a whole bunch of training there and came back to Canada and started the field of oncology rehab. So together with cardiology. So that's a field that is actually growing, and something that for trainees who are interested in the field should keep an eye on that. Wonderful. Any other comments? And
Mike, could I ask a
yeah,
quick
go ahead.
question? I don't know if we have time for this. I don't know what the research is, but I remember hearing them talk about this when I was at McMaster. Essentially, has anyone looked at what the patient preference is if they are faced with mild cardiomyopathy secondary to Herceptin or anthracycline, and their preference with discontinuing therapy or continuing therapy, and whether there's been any research looking at